today we have the pleasure to have a living legend, Maha Hussain. She's a such character. She knows what she's going to be and to become since her childhood. She was born in a family of physicians, scientists, and when I'm not revealing any secret about her genome, because she has a gene of medicine since the childhood. Maha Hussain, welcome to Morocco. This is your first visit, and we have great privilege to have you talking about this sequencing therapy in hormone castration-resistant prostate cancer. You are a professor of medicine. You're a genitourinary cancer specialist and international expert with a special interest in bladder and prostate cancer. You have written more than 300, more than that, I guess. I don't, it's countless now.
That's what I say. Sleep is overrated.
Yeah,
so don't sleep.
On different topics on prostate cancer, and you have a lot of book chapters. We've trained so many fellows and young faculties. Some of them are now holding key positions around the world. You have been awarded the most exceptional woman in medicine. You have you're rated as one of the giant in cancer care. So many awards. I can go on and go on. The list is limitless. Okay, so Maha, you will be talking about sequencing therapy, and we are all here to learn from you, from your experience. You can see from the audience that male to female ratio is changing in Morocco, and more female are now getting involved in the field of oncology and radiation oncology, and probably in the future, even in urology. Thanks to me. Sure. Maha, it's a pleasure to have you. Marhaban bik.
So I do have to say I'm biased, and I always say girls will save the world. So that's what's going to happen. So thank you so much, everyone, and I really want to thank especially Dr. Izzadeen and Dr. Zain for their hospitality and everything. It's really been a pleasure. I've never been to the whole continent of Africa, let alone one country. This is my first visit there, and you have a wonderful country, beautiful, everything, lovely people. I still have to get used to the accent. That's the part. So it's hey, my ears are working. This is happening. So I would like us to perhaps, if you want, we can keep it sort of informal. And as I'm going through the different things, if a question surfaces, as long as we're not going to go way too much over time, because you want to go back home, I'm sure. You can feel free to raise your hand, and I can address the question, and that might work better. So therapy sequencing has become a big issue in prostate cancer, and partly because with the whole last 7 years has been really dramatic in terms of new drug approvals that are really leading to impactful outcomes for patients, primarily prolonging life. And the minute you have a drug in the advanced stage of disease that is life prolonging, it moves up into the earlier phase of that disease and then goes into the hormone sensitive and then to the adjuvant setting and the PSA only relapse and things like that. And so really there's been a lot, and in the reality there's never going to be perfect plans because there's never going to be perfect clinical trials that are going to address every one of these questions. So I do think decision making is going to be a combination of what data is available, what your sort of wisdom is in terms of the medicine part of it, what is feasible for the patient, and ultimately shared decision. But there's obviously several clinical trials that at least right now define some major guidelines for us. So this is the US history of drug approval, and believe it or not, from 1940s till 2004, there were really no life-prolonging treatments for patients with metastatic castration-resistant prostate cancer. It wasn't, of course, we had mitoxantrone, but that was not life prolonging. So it wasn't until 2004 when docetaxel for us in the US got approved. That was the first drug where there were 2 clinical trials that were positive for overall survival benefit. And then that was in 2004, and then afterwards we got a series of drugs that were approved, basically Sipuleucel T, which is the vaccine or immunotherapy. Do you have it approved here?
No.
Okay, it's okay. It's what I call faith-based medicine. It's not, yeah, it's like you give it and you cross your fingers and toes and hope that it's going to do something because you have no way of measuring benefit with it. So Sipuleucel was approved, cabazitaxel, and enzalutamide, abiraterone, and the enzalutamide 2 approvals and the abiraterone 2 approvals were based on the fact that they were first tested post-chemotherapy in the castration-resistant disease, then got moved up into the first-line setting of castration-resistant disease. And then, of course, the era of precision medicine was in 2020 for us, with both olaparib and rucaparib being approved. And then we got lutetium PSMA, and I don't know if it's approved for you right now or not. 2022 it was when it was approved for us, but it's been a very dramatic situation with it because there's been huge supply issue and lack of availability. So even myself, probably since it got approved, I may have treated maybe 10 patients at most, and yet my practice is like 80% prostate cancer. Now, one thing I should say, there were 2 other drugs that were approved for essentially skeletal-related events. And again, I don't know if you have it, zoldronic acid or Zometa, and then denosumab is the other drug, both approved for skeletal-related events. Both, I should point out, are to be given in the context of metastatic castration-resistant disease with bony metastases. So if you have people who have castration-resistant disease, but it's not in the bone, lymph nodes, lung, liver, whatever, really what you want to do is not give the monthly infusions, but rather check their bone density, and then maybe do it as a way of, if they have like a risk of fracture risk, there's a formula that you can follow, then you can give it for more of a bone health perspective. And then pembrolizumab, which is immune therapy, was approved actually in 2017, but this was as part of a generic approval. It's any tumor that has basically MSI high or MMRD present there. And I have to say the rate of positivity for this to apply, honestly, 3%. When I look at my patients, I have yet to see a single patient myself that actually tested positive for these. So, but anyhow, it's something that's potentially available. Now, this is the list of drugs that have been approved. Actually, when I say approved, it's really because of the level 1 evidence that have been tested and demonstrated efficacy in different clinical settings, and the survival improvement agents are highlighted in here. And I want to highlight here that both abiraterone, enzalutamide, apalutamide, and darolutamide are approved in multiple disease settings. So enza, apa, and dara is approved both in the non-metastatic castration-resistant disease, and then of course they are approved also in the frontline metastatic hormone-sensitive space. And abiraterone is more in the frontline castration-resistant, also hormone-sensitive space. And then rucaparib, interesting, as I'll show you, there's emerging data with it from phase 3 clinical trials. I don't know what will happen, at least in the US. At this point, it's actually approved based on clinical benefit, but there is an early signal of from the phase 3 trial that was presented at ASCO GU with PFS improvement and an interim overall survival positivity. It's still, I think, not there exactly yet. Now, I don't know if we talked about the non-metastatic castration-resistant prostate cancer space, and this is kind of a touchy subject because it's all is based on the fact that you have patients who have castrated testosterone, PSA rising after prior therapy, they are on hormone treatment, and you do their conventional imaging, and the conventional imaging is negative. So when we call it non-metastatic, I want to highlight, this doesn't mean there's no micrometastases, it's just that you're not seeing them at this point. And for the residents and the team, as I tell my patient, a sphere this big, do you know how many cells there are in there? Take a guess. 1 billion cells. So the reality of it is this, is if you have, I don't know, 10 million, you're not gonna see them. And yet they're gonna make the PSA and you're gonna measure it. So we have to be careful when we use the lingo in that regard. And so what happened is then 3 phase 3 clinical trials were done, looking at, again, this particular space with apalutamide, enzalutamide, and darolutamide. And these trials actually, all of them, clear separation of the curves, favoring the androgen receptor inhibitor based on these particular trials. Again, these were, at least for us in the US, led to the approval. The reality of it, this patient population now that we have the PSMA PET is changing the scope, and now you're beginning to see metastatic lesion. And the reality too is that if you think about it, these patients are on hormone treatment. Technically, and again, I don't know what the PSMA PET approval here is, but in the US, when it got approved, it was approved actually for purposes of patients who are with a rising PSA, but not on treatment. And for disease monitoring, not on treatment. So, and part of it is because you can get false positivity and a lot of like nuances in there, so. All right, so the treatment sequencing questions really became an issue, and it's a good problem to have actually, because we have more drugs now over, I wanna say, the past 10 plus years. And so this is a list of the questions, and actually there are more, it's just there were not enough room in the slide to add them in there. But just to highlight it, is it, when you're talking about frontline metastatic castration-resistant patient, which is better? Do you start with Abi and or Enza or chemo? Because docetaxel is proven, abiraterone is proven, enzalutamide is proven. So which one do you go to with? What about switching therapy? Abi followed by Enza, or Enza followed by Abi, or another pathway type agent? Which one is better? AR targeted therapy, so somebody is on hormone treatment, they've never seen any AR inhibitors, maybe just bicalutamide or something, and now they've progressed. Do you want to give them another AR inhibitor, then followed by docetaxel, or all of these things, like really, there's multiple questions that we have to think about there. And what about docetaxel in patients who might have seen docetaxel for hormone-sensitive space, sort of per-charted, and then 3 years later they're castration-resistant? What is the value of reintroducing it into the treatment? What about dosi versus Kabazi? Where does radium best fit now that we have the lutetium PSMA? And then what about precision medicine and targeted therapy? And what about clinical trials? So I actually listed all these questions, and some of these questions have been answered, or we have some answers for them. So what are the emerging data? So what is clear is that more is not always better. So dumping things on patients without really proven evidence is probably not a good thing to do anyway, but when it was tested, trying to kind of gang up on the cancer with multiple pathway, AR pathway inhibitors, it did not deliver. So enzalutamide with and without abiraterone, this was a phase 3 clinical trial reported earlier. Mike Morris actually just got the paper published just recently in JCO, but basically there was really no advantage. Abiraterone and prednisone plus minus radium, and this was actually a trial that we participated in, and also it did not deliver either, and so no point in doing that. Therapy sequencing questions right now that I'm going to be addressing in the next few slides is the AR targeted therapy sequencing, and how do we look at that? Cabazitaxel, where does it fit? PARP inhibitors, where do they fit? What about radium? And then what about lutetium PSMA? So this is the enzalutamide. This is data from the Canadian group, actually. Kim Chi, I'm sure you're aware of him or have heard of him. He's a major Canadian GU medical oncologist. So they conducted a clinical trial, which really is a great trial that they did because it at least delivered some questions. So if you're going to be treating patients with castration-resistant disease, assuming the patient is fit enough to receive either Abi or Enza. Remember, there are certain subtleties in terms of what you're going to be, choosing. Assuming the patient is fit. So what you're looking at here, essentially, the summary of all the slide is Abi followed by Enza, the ENZA had a chance of working. If ENZA was given as a frontline, Abby did not have the chance of working, basically. That's really the summary of it. Now, the question is why? You're targeting essentially the pathway. Yes, one is an AR receptor inhibitor. Actually, the blue, which is the ENZA, they do better that way. Now, again, when it comes to the everyday practice, you have to also be mindful of a few things. And I don't know if you have pharmacists in your own that you can talk to, but I would strongly encourage you to touch base with them, because ENZA is a tricky drug. It has a lot of drug-drug interactions. And so you have to be mindful of making sure that you are talking with your pharmacist in your hospital for them to look into these sort of subtle nuances. Abby is an easy drug to use, but you're talking about issues of monitoring electrolytes, monitoring the liver function test, looking at, prednisone, somebody's diabetic, are you going to give them BID doses of prednisone and things of that sort. So, but making a decision is going to be critical up front, not worrying about what's going to happen down the road, but this data is important. Is it worth trying, let's say somebody was not fit enough for ENZA to start with, is it worth trying after Abby? I would say you have to be mindful and careful as long as there's no major contraindication. One of the issues with ENZA that can occur, and AMPA the same thing, and I've have it happen to my patients, is risk of falls. They kind of lose balance and then they fall. And then the other thing is issues of ischemia, cardiac issues and things like that. Overall, though, they're very well tolerated. This is the story about Kabazi versus Dosi. And this is essentially first line. And when you look at it, you can't even put a laser pointer in between the curves. There is no advantage for Kabazi over Dosi. And that's not a surprise. They're both within the same pathway. And so you would not expect any big issues. The interesting thing, though, there's, and I'll show you positive trials afterwards about Kabazi given after Dosi. So this is the Kabazi versus abiraterone and enzalutamide for metastatic castration-resistant disease in patients who have seen docetaxel before. So this is second line, is technically castration-resistant disease. Or third line for that matter. And basically, these are patients who essentially, if they've seen Abby or Dosi for castration-sensitive or hormone-sensitive space, they were allowed to be in there. And then looking at basically the final efficacy was a progression, as long as the patients have not progressed, in less than 12 months, they were allowed into the treatment. The primary endpoint was radiographic progression-free survival, and then there were secondary endpoints. And it's really very clear here, Dr. DeWitt from the Netherlands, and they've done really, it was an international clinical trial. And what you'll see here, really, the Kabazi-Taxol did better than the AR inhibitor, essentially. And that's not a terrible surprise, I would say, because you're talking about downstream patients. And this is the overall survival data, and this is the progression-free survival data. And when you look at the hazard ratio for the patient benefit across the board, there was a patient benefit. So in my practice right now, when I'm using it downstream. If a patient has already been through AR inhibitors, docetaxel already, they don't have like BRCA or something like that, then this would be a good option. And surprisingly, actually, it's very well tolerated. And again, for the fit patient, even I have patients in their 80s, but they're fit, like they're running and they're doing things. It's really can be given reasonably safely. And just to be clear, is the 20 milligram per meter square dose. Yeah, not the 25. Yeah.
Accumulated toxicity.
Pardon?
Accumulated toxicity.
I would say before we had a lot of the drugs like what we have right now for castration-resistant space, we were able to give Dosi, then Kabazi afterwards. Again, it's a risk, but from my experience, it's not as, I think Dosi, for some reason, at least for my own experience, Dosi seemed to have more marrow issues or, but again, now that we're giving it much earlier, it's like in the hormone sensitive space, you know, it seems like the body recovers, and so it's not much of an issue, yeah.
With the dose of 16, the Castration trial, 16 milligram.
For dosing?
No, for Castration, 2 weeks.
Oh yeah, the bi-weekly, yeah, those, yeah, that's not delivered. So right now is the every 3 week schedule, 20 milligrams, yeah. And just for the sake of time, I did not put that slide because it's not changed the practice, yeah, yeah. Any questions so far? Yes?
I have a question about the trial about the trial that discuss Abergeron after enzalutamide or enzalutamide after Abergeron. In the real world, in our practice, we don't choose to do twice time a third generation hormonal therapy. Maybe if we do Abergeron after that we do chemotherapy and not to try ENZA after Abergeron. What do you
Yeah, I think it all to do with how urgent is the need to do something. Remember right now, a lot of the patients when we see them, a lot of the issues are driven by the PSA, right? So you're seeing somebody, they're asymptomatic, and you're monitoring their PSA, and the PSA goes up, and I would recommend always testing it at least twice, maybe a month apart or something. And so if there is only a PSA change and now you're doing the scans and there's not a huge change in the scan, like maybe one lesion, maybe more intense or like one new one, the patient is asymptomatic, where you feel comfortable there is room to test, then I don't think it's wrong to consider, if they were on AbbVie, to try ENZA, as long as there's no major contraindication. I've also done occasionally this, which, sometimes if somebody's been on ENZA, I might try AbbVie, but with the data that we have right now, I just feel like it's not worth bothering with AbbVie after ENZA.
So it's not a question of sensitivity. If we give a taxane between the two AR.
There is that question, but one of the factors is chemo is chemo. Yes, it can be well tolerated. Yes, we can do it safely. And in the US, we actually routinely use growth factor and all of that stuff. But the reality of it, it's chemo. And there are times where the patients are reluctant. The minute they hear that word, they kind of get scared. And so if you feel comfortable that the patient is not symptomatic, it's safe to consider no major risks in terms of falls and cardiovascular issues and things of that sort, I don't really think it's wrong to try. It's one of those things where you're going through the checklist of the drugs you have,
And the trial it was for the patient who progressed under 1 year.
Yeah.
Patients who progressed after 1 year, maybe.
Yes, perfect, absolutely correct, yes. And that's a great point. If a patient went on AbbVie and 5 minutes later they progressed, I don't mean literally 5 minutes, but 6 months or less than a year, I would jump into more of the chemo. But somebody who might have been in response for a longer period of time, the AR AR continues to matter, and this is, sort of attacking it in a different manner may actually be useful. Yes?
If you have a quick progression after Abergeron or ENZA, we did another biopsy to show such neuroendocrine composition, no?
So that's a great question. So, so the question was, if you have somebody rapidly progressing, would you do the biopsy to rule out neuroendocrine progression? So I would say selectively yes. Especially if a patient is progressed with visceral disease, lung or liver, I definitely biopsy. In fact, I have just one patient just biopsied now because the liver worries me. And in my experience, and that's the anecdote part, is that I've seen patients actually convert into small cell sometimes. A lot of times it can be neuroendocrine. One of the subtleties about neuroendocrine is not all neuroendocrine same. So you have to be mindful about what you're looking at. But we definitely, anybody who progresses that way, you biopsy them and it's still prostate cancer, conventional adenocarcinoma. Definitely I would say when you have visceral metastases or significant disease in the bone and whatever, I usually jump to chemo and not go into an AR inhibitor. Yeah. Okay. So then I want to talk about, so treatment sequencing, like anything else, generally the areas where there are unmet need is generally where the newer drugs get tested. And that's true, as I showed you, in terms of like the list of the drugs that were approved, that invariably get tested in the end stage disease and then gradually move up the path there. So it's kind of part of that story of treatment sequencing there. And so when we designed the PROfound trial, the PROfound was meant for patients, because not everybody might be fit enough to get chemo. We just wanted to do it in the second line, technically, at a minimum, second line castration-resistant disease. But we allowed actually patients who have seen multiple AR inhibitors before, might have seen chemotherapy also or other agents, and I'll show you some numbers. And again, with the PROfound, because of what I call the canonical, as in like the conventional genes, are the BRCA1, 2, and ATM. This is in breast and in other cancers. So we kind of separated the cohorts because it wasn't clear what how well the other genes that are non-BRCA genes will respond. And then crossover was allowed in the trial. And so this is basically sort of the overall survival data. The primary endpoint was actually progression-free survival in the primary cohort, and then which was positive. And then literally we had overall survival data available shortly after, and where we reported it, and it's listed in here. But I want to highlight here that 65% of the patients, aside from having an AR inhibitor, and some of them have had more than one AR inhibitor, 65% of the patients have seen prior taxane in the castration-resistant space. So this gives you a feel for the treatment sequencing. And interestingly, that in both cohorts, actually, there was a clinical benefit in terms of disease control and progression-free survival and overall survival benefit in there. So one of the issues, and these are what we have in here is because again, we allowed crossover. So this is essentially crossover adjusted analysis for the patient's cohorts. And you'll see here is that the gaps are even bigger compared to what it was. And in the paper, actually, and I had made sure that we include all of the information on how many lines of prior therapy, just to give you a feel for responsiveness in this setting. Now, what's clear is this: the olaparib, and I think my guess is going to be all the PARP inhibitors. Where they're going to work the best is going to be really in the BRCA1, 2 ATM situation. Some of them don't work in the ATM situation. We can talk about it afterwards, but definitely they will work in the other cohorts also. So if you have it approved, and again, that's an issue, and depending on what is the approval for your country, you can try it within that panel. Now, one of the questions that, again, I had wanted us to look at exactly the treatment sequence as it relates to chemotherapy. So how does a person respond? And again, this is in the paper. It should be there. Happy to share with you. Email me. I can send you all these slides. But basically what was there is that when you're looking at the BRCA1 or BRCA2 group, basically, irrespective of prior taxane exposure, there was benefit. What you can see is that the benefit seems to be more in people who have not seen taxane. Now, that doesn't mean it's a bad situation. What it means really is you have less complicated cancer, meaning like it hasn't developed as much resistance potentially as people who have not seen or who have seen the taxane. When you're looking at the CDK12 patients, the patients who had no prior taxane exposure seem to respond. Those who had prior taxane exposure did not. I want to be clarifying one thing. The majority of these patients who have seen taxane was technically, generally speaking, in the castration-resistant space, not so much in the hormone-sensitive space, just because of the timelines of the study and the data from Charted. Then, of course, the ATM situation was the reverse, is that the patients who have seen no prior taxane seem to not benefit, but if they've seen prior taxane, they will benefit. Now, I put this in there, again, this is a post hoc analysis, but actually was prompted by experiences I had with my patients, and we wanted to kind of delve deeper into the data set from this. Having said that, again, depending on the situations, you might want to consider this as you are deciding on treatment, knowing fully that a good number of your patients are likely going to be seeing Taxotere in the hormone sensitive, so then this whole thing doesn't matter anymore. All right, so Recaparib, this was actually presented at ASCO GU, and then the paper came out with Dr. Fizazi, from Dr. Fizazi and the team for the particular trial. Interestingly, the trial, I think, had a very nice design because it did compare the Recaparib versus chemo or second generation androgen pathway. Now, I will tell you that, again, it's surprising that when they did the trial, that chemo, they had not had patients have received chemo for hormone sensitive space, if you think about it. But anyhow, the benefit is strictly in the BRCA population, not in the ATM population. And it seems that the benefit, irrespective of DOSI or second AR inhibitor, either way, Recaparib did better in terms of the outcome. And there was actually a trend on the overall survival, but it's really not yet mature completely. So there's benefit in there. Now, Recaparib for us in the US is approved based on quote unquote clinical benefit at this point, you know, like a response. I'm not really sure what this data will do in terms of adjusting the FDA approval and indication. All right. And just to highlight the sequence story, and I mentioned this in my presentation yesterday, this was more of a trial that was, when I designed it, was looking at is two better than one, and is one after the other different than the other one after the other kind of thing there. And so this is basically the outcome, and what is really clear is ABI upfront for castration-resistant space, or olaparib upfront, give and take, they're about within the same ballpark in terms of the effect. When you're using the combination, it has a better signal. And we are finalizing the paper, but we looked at the crossover, and the whole idea was, can you come up with like a graph that might show these moving up here? The answer is no, at this point, yeah. Okay. All right, last but not least is PSMA treatment, lutetium PSMA. Is it approved here or no? Not yet? Okay. Okay. So you don't have to live through the drama of availability. Supposedly it's getting better, but we'll see.
PSMA scan will be coming month, but
PSMA PET.
Yes. Yeah, because you have to, yeah, there has to be a PSMA PET testing. Yeah, yeah. Yeah, absolutely. So basically, this trial again was in the second line setting, but really, but in reality, a lot of the patients have seen multiple lines of therapy. So the nice thing that it at least has efficacy technically in patients who've been heavily pre-treated. And this was from the original presentation that Mike Morris did at ASCO with the study design and highlighted in there. But one thing I want to say is that previous treatment with both one or more AR inhibitor was allowed, and one or more taxane was allowed. So a good number of the patients have seen pretty much all the AR inhibitors and the chemotherapy and stuff like that. And this is basically the final analysis and reported outcomes. And essentially the progression-free survival and the overall survival is definitely better. And so this is really a great opportunity for patients for treatment. One thing I would say, like anything else, once we start using these agents, you sort of start to kind of discover different issues. So I had just one patient right now where his marrow went flat, and they biopsied him, and he doesn't have any specific like prostate cancer in multiple cores that were taken out, and yet there were not many cells. And so is this because of this? Is it because of something else? I have no idea. But all I'm saying is we're all learning how to use these drugs, and you have to be mindful of the subtleties because primarily you're hitting the bone marrow with radiation, essentially. Okay. And then we're going to go down to the different PARP inhibitors that are going on. And when I was mentioning, a lot of these drugs, PARP inhibitors, are moving in some of the earlier stages of the disease. And so I think it's going to be an interesting situation to see how they fit in there. There are several phase 3 clinical trials with combination, but they've moved, all of these trials, by the way, have moved the PARP inhibitor combination into the frontline castration-resistant disease. And so, again, that's an issue of sequencing. We've shown benefit, moving it up. And this is the PROPEL trial, which the overall survival data is being reported. And the bottom line was that the radiographic progression-free survival was beneficial, but when it comes to the overall survival, the benefit was in the HRR mutated patients, but not really in the non-mutated patients. And for us, the FDA, I mentioned yesterday, for those of you who were in there, just had what they call the Oncology Drug Advisory Committee meeting, and they discussed all of this, and interestingly, and not surprisingly actually, and I would say wisely, the majority voted to support the pre-selected HRR positive patients, but not the negative patients. And then Talapro was also reported. Interestingly, again, because PROPEL, when you looked at the PFS, there appeared to be a benefit in both. Here, Talapro, same thing, seemed to be a benefit in both HRR deficient and non-deficient. The question is going to be, is it going to be like the situation with PROPEL? Is that, are you going to be seeing no advantage in overall survival, or you will? So to me, I think it's important to wait for the overall survival data in that regard. And at this point, surprisingly, while the median is almost there, as you see here, like this is the 50%, the curves are like that for the overall population. So it'll be interesting to see. All right. And of course, more complications, I should say positive complications, are occurring is because a lot of the positive agents, especially the oral agents, the chemotherapies, have moved into the earlier space of the disease in the hormone sensitive, and all of these agents actually have demonstrated an overall survival benefit. So then this is going to raise another layer of complexity when it comes to therapy sequencing. One thing is you're going to start a patient with, say, docetaxel and hormone treatment. That's easy. But if they progress after the 6 cycles in 2 years, and let's say you cannot get them ABI or ENZA, should you give them chemo again? You know, and if that's chemo, is dosi going to work, or should you use Kabazi? And my gut feeling would be is probably try to get them an AR inhibitor if you can, and it doesn't hurt to try dosi and see if it works, but not, you know, definitely Kabazi. So there's going to be a lot of subtleties in there. With the AR inhibitors, it's sort of like a no-brainer because you don't ever stop the treatment. You continue giving it all through. But then somebody who's been on ABI, and we had shown that ENZA after ABI has better effect as opposed to ABI after ENZA, but that's in the castration-resistant space. What happens if somebody was on ENZA and now they progress to castration-resistant? Can you use ABI? There's really no data, but if a patient is asymptomatic, you're monitoring closely, I don't think there's harm in trying in terms of like the everyday practice situation. And of course, the drama is even more when you're talking about triplet treatments. But the hope is that with these triplet treatments, the patients can continue in a longer duration of response, and hopefully there will be emerging data on potential next generation of agents to use, right? So, I think this is almost my last slide, and I am between you and dinner, I think. So, but one thing, no dinner? Okay, that's good.
Dinner.
So basically, I highlighted all these agents here. These are all agents that have demonstrated an overall survival benefit. And what's highlighted in yellow are agents that are approved in multiple disease settings, proven in multiple disease settings in terms of benefit. Hormone sensitive, castration resistant, non-metastatic castration resistant, and so on. And then olaparib and lutetium are both, lutetium PSMA are moving into actually frontline setting of hormone sensitive, of castration resistant space. And actually olaparib, I believe there's a hormone sensitive trial going on with it. And so all of these agents are shifting into the earlier stages of the disease. So what are the clinical considerations when you're in the clinic? Basically, looking at what the patient had received for their hormone-sensitive space or non-metastatic castration-resistant space. What are their performance status? What are their symptoms? What are their comorbidities? What are the chance of the patient being able to tolerate what you're going to prescribe versus not? Because again, do no harm is your #1 principle in treatment. Is the drug available? What about the cost factors and logistics? And what about the genomics, and what is the patient preference? Now, one thing is this, it's gotta be a shared decision. You've gotta advise the patient, and you're gonna have to also advise them in an independent manner. But at the end of the day, this is what, sir, this is what I think, they ask you what your recommendation is, you can give it to them. Ultimately, they have to decide whether they're comfortable with it or not. And of course, access to clinical trials always is a good thing. So I think I want to just quickly go through this, just sort of capture everything. I think there's been tremendous progress, no question about it, honestly, compared to when I entered the field. Median survival at the time when I entered the field, castration-resistant disease, was 9 months. 9 months, it was definitely under a year. So now we've really moved into almost, four times, exactly, yeah. One thing we know is this, in previously treated patients with AR inhibitors or docetaxel in metastatic castration-resistant disease, Kabazi, radium, lutetium PSMA, and olaparib, all of these agents prolong overall survival. I should point out olaparib strictly in the HRR mutated patients. The current data indicate that sequential AR-targeted therapy, ABI-ENZA situation is not very impactful. But what about sequence of the same in-class agent and sequence in different disease settings? So somebody who was on, let's say, ENZA for hormone sensitive, will APA work for them in the castration-resistant space and things of that sort. We don't really have the data at this point. I think better efficacy, emerging data with better efficacy in the HRR mutated patients with combination AR inhibitor plus PARP inhibitor. So it will be interesting to see, the different agencies. And then moving effective treatment to earlier disease state has a better, Which slide?
This is
Technical.
No, this is fine, but my question is which slide, at what
So
slide you lost it?
conclusion.
Oh, conclusion, okay, yeah. You know what, my conclusion is what I discussed with you, so we don't have to delay it.
Maha,
Yes.
outstanding as usual. We have a
Yes.
few minutes for
Uh-oh.
question.
Yeah. Well, I'll tell you what, what we can, we don't have, there's not much really, it's just the conclusion, so we can go through the questions, not a problem.
Just one question. In practice, Maha, do you
Yes.
select your patient who will not be a potential responder by doing genetic testing before putting them on IB or ENZA? You see there are some patients who will not be responding anyway, the one with BRCA.
Oh, you mean,
BRCA2,
I don't
or
know.
ER-V7.
No, I don't measure the ARV7.
Yeah.
There are, I would say when it comes to AR agents, that's sort of generic situation where you just give it if the patient is fit enough, and as we talked about, there's data with it. When it comes to the essentially targeted treatment, like if you want to use IO, Pembro, for example, or olaparib, then you're going to have to test them. Yeah.
What's the best time to carry out test now?
So I would say it depends on the circumstances. If a patient is de novo metastatic disease, and as we were discussing earlier, you see a large number of those patients. I would actually, when you do the biopsy, especially, it doesn't matter if it's the prostate or metastatic site, I would actually send it for testing. Now, the issue I think for you is the ability to be doing the whole panel of testing and not just the BRCA. Yeah. And so if you're not able to do that, that's fine. At least get the BRCA stuff. But it would be nice if there is a way of getting the whole panel, because downstream, as more research is going on, there may be drugs that might be targeting, other pathways. That might be, P10, something like AKT, stuff where the patient, you might be able to use it. The one thing I would say, as I mentioned, I think yesterday, one thing we know that when we did it, we looked at the we looked at the quality of the tissue based on duration of the tissue. And essentially, the more fresh the tissue, the better chance you're going to be able to test it. Doesn't mean it's going to be positive, but from a quality testing. Yeah.
Do biopsy, new biopsy in progression?
I sometimes will do that, but not always. So we looked at primary versus, metastatic disease. I would say I like to do it if your primary tissue was, if your original tissue was the prostate, and you're trying to look for something, and the prostate tissue, you tested it for like NGS, and there's nothing. I would go actually and test, I would do a fresh biopsy and test there, because there could be, like the tumor evolves and then you could see alterations that it wasn't there in the primary. Yeah. And then just to make sure that when you're really doing the biopsies, a lot of times interventional radiology may do an aspirate. No good. Tell them you want a core, and preferably multiple cores, because so that you can get adequate numbers for testing.
In our practice, you select patients for the treatment, just patients with visceral metastasis?
You mean for in the hormone sensitive?
Yes,
Hormone sensitive. So I would say definitely if a patient has visceral disease, I would definitely err on the side of triplet treatment. But in reality also, I will use triplet right now. Again, we didn't go over this time, but in my earlier presentation a couple of days ago, basically what we know is this, is the triplet, whether you're using the PEACE-1 data or the Arison's data, the benefit seems to be across the board for patients. Now, there are subtle issues, like you see somebody who was diagnosed 10 years ago with prostate cancer and now relapsed, and they have 3 retroperitoneal lymph nodes and nothing else, and the guy is 75 years old. Do you really want to give them chemo? So there are some issues that you would have to use some clinical judgment, but technically speaking, as we speak right now, the benefit seems to be across the board with the triplet treatment. What is not clear is you really have to do a triplet with chemo versus doublet with an AR inhibitor and ADT. I'm not really sure. I mean, this is an opportunity for clinical trials to be done. You'd have to figure out if pharma is going to do it or not. Otherwise, you have to have maybe sort of the national situation, like the cooperative groups, like the European cooperative group, or SWOG or ECOG or something like that, do these questions. Yeah, it'll be a while before to get the answer. Yeah.
This is the question, to compare combination with ADT plus RP. It seems to be the combination to do it in hormone sensitive. Why not in CRPC metastatic combination?
You mean triplet?
Triplet, yes.
I think that's a great question. I don't know that it's something that's...
Now we are doing RP plus olaparib. Why not chemo with the enzalutamide or apalutamide?
Yeah, no, you're absolutely correct. The reality of it, though, is there's the issue of toxicity. And so when you're going to be doing something, do I think, like if you do enzalutamide or apalutamide or not, I think you're going to see the same benefit, my gut feeling. But it's the issue of toxicity and what is the magnitude of benefit, and more importantly, can you get it covered? For us, insurance is a factor, and there's no data on the triplet as it relates to safety and tolerability for the other drugs.
One question is about several months ago, we used to use the abiraterone because there was a problem for insurance recovery for patients, and we used one pill a day during the
With food, yeah.
Yes, with food, and several patients progressed. We used chemo with docetaxel. And now the problem for insurance is being resolved in Morocco. So, are we allowed to re-challenge with 4?
Actually, what I would do is you go with the 4. So I understand when you have a supply issue is one factor, but as we were talking about earlier, so the crowd that did with food is our neighbors in Chicago, the team from University of Chicago. And I think it's a great concept. The problem is it's not validated by prospective phase 3 data. And so you could see a signal, but it isn't just about PSA going down. right? It's all about the totality of the benefit. And where there is data right now with abiraterone is basically with 1,000 milligram per meter square on empty stomach.
But I'm asking if he progressed.
No, I understand. You can try going up, but I cannot tell you that we know that there is any information. But definitely, I would say if right now the insurance allows you to give for the 1,000 milligram, just go with that first. If you see any potential benefit in that situation.
Last time we were talking about novel metastatic coming to your practice in US. Tell us just what's the percentage in US, so we'll not be ashamed of ourselves here in the emerging countries.
No, don't be ashamed. Honestly, I cannot tell you the statistics there. I would say surprisingly, this began, and I was mentioning, we were chatting earlier, surprisingly, I began seeing de novo metastatic disease at diagnosis literally almost now 10, 12 years going to my days in Michigan. And we were chatting about these. These were not Black patients, these were not poor patients, these were not patients who were not getting health care. It just is acutely, suddenly, and hardly much family history. It was like a very odd situation. And so, so don't be ashamed. Having saying that, what I would say is, what I've discovered is a lot of people in primary care aren't always up to date on what needs to be done in terms of maintenance health. And then the other part is really educating the patients. And again, I don't know if there's any kind of forums, but this is what we're talking about, is maybe have a forum and sort of spread the word through, I don't know, mechanisms of, internet, Twitter, whatever, and maybe TV, that you're doing a forum educating men about prostate cancer. Yeah, and I'll tell you, people will show up. My guess is this, yeah, because it's something very personal, and they will show up, and you can think about maybe offering them, exams and things like that. PSA, whatever, rectal exam. Yeah.
Urologist.
Yeah. Although I always say rectal exam is gentler with the ladies' fingers. It's much smaller.
Man, thank you very much. That's very kind of you to share with us all this information about your experience. So thank you for our sponsor, and thank you for everything.
And thank you all. This was really a pleasure, and it's a delight to know you all and mix with you and chat and everything else. So, and for hosting me, so much appreciated.
You are always welcome. So, girls, come here for a picture with me. First.
Only girls.
Only
What?
man later.
Listen.